And for those who may be new to ECHO, this is a model that builds virtual communities of practice and learning. Sessions include a didactic presentation and de-identified case-based learning and group discussion to foster deep knowledge and build individual capacity. ECHO is an all-teach, all-learn supportive model, and ECHOs thrive on the interaction from the full learning network. So we encourage all to participate in the conversation today. Next slide. And to receive CDE credits, please make sure to be on the session throughout the duration of the presentation. If you would like to receive CDE credits, please register through Smile, which you can do so now using the link in the chat or by scanning the QR code you see here. When registering, please use the supercode ECHO 2025. And we will leave this slide up while we do team introductions, followed by presenter introductions. The director of this program, Dr. Challa, please introduce.
Thank you. I'm Suman Challa, and I have this grant that supports this DentEcho, and thank you all for being here.
Thank you. And then from the Hub team, we have today Dr. Marwaha, Dr. Okay, and then Vanessa. And the next slide, and Dr. Dar, as you introduce yourself, please go ahead and also move on to presenter introductions.
Thank you so much, Kito.
Thank you.
Hi, everyone. I am Shohini Thar, and it's my ultimate pleasure this afternoon to introduce our two speakers for today's session. Dr. Shobna Mishra is a clinical assistant professor with our institute. She earned her dental degree and master's in oral medicine and radiology from India, her residency in orofacial pain at Tufts University School of Dental Medicine. Dr. Mishra's clinical and research interests focus on neuropathic pain conditions in orofacial region. Welcome, Dr. Mishra. And our second presenter for today is Dr. Asma Khan. She is a tenured professor at UT Health San Antonio. She received her dental degree from India, her PhD in neuroscience from University of Maryland, and her certificate in endodontics from UT Health San Antonio. Her research interests include the use of AI to improve clinical practice and the development of new diagnostics and analgesics. Thank you both of you for being our presenters this afternoon, and welcome.
Thank you. Should we go ahead and share our slides now?
Okay. Yes, please.
So while you're doing that, thank you to the ECHO team for this opportunity and also for all the people in the audience for joining us this morning. So I think what we have for us is a very interesting topic of conversation. It's really trying to identify trigger points which might present as orofacial pain or as a toothache. So essentially, when patients present with a toothache, we need to have the right diagnostic means to identify if it's a true toothache or not, and then how do we manage them. So I'm very glad to have Dr. Mishra as my co-presenter here. Thank you very much. So let's start off with a simple case. So this would be, well, it appears that it doesn't want to start us off. Let's try to do this. Okay, wonderful. So this is one clinical case scenario that presents quite often. So here is Mrs. Jones, a 65-year-old woman who presents with the chief complaint of severe toothache. Her medical history is non-contributory. Mrs. Jones says that she has been having this pain, which she rates the intensity as 8 on a scale of 0 to 10 for about 3 weeks. The pain is made worse when she chews her food. She has been taking over-the-counter medications, essentially ibuprofen and Tylenol. She says that these medications can attenuate the pain a little bit, but they do not take the pain away completely. So when we did our standard oral exam, we couldn't really replicate the patient's chief complaint. So the tooth was not sensitive to palpation. There was no pain on percussion of the tooth, but using the tooth sleuth did exacerbate the pain, but not to the extent that the patient had. The tooth responded to cold in a normal manner. The probing depths were less than 3 millimeters. And then we took both 2D and 3D radiographs of the tooth, and we really could not identify any pathology. So both the crown on tooth number 31 and the implant were placed over 3 years ago. So when there are situations like this, when the patient is having pain, and yet we cannot identify the source of pain, we cannot replicate the chief complaint, it always raises the question, is this a true toothache, or is this pain being referred from somewhere else? So this is where my colleague, Dr. Mishra, comes in.
Thank you, Dr. Khan. And this is an excellent case scenario where we'd like to discuss about the fact that not all toothaches are the same. They could be either odontogenic, which could mean that the pain is arising out of pulpal etiology or a periodontal etiology. On the other hand, the toothache could be non-odontogenic, wherein we know that it could arise from some other source. It could be musculoskeletal, neurovascular, neuropathic, or idiopathic. And for the purpose of this presentation, we'd like to focus only on the musculoskeletal aspects of non-odontogenic pain. Now, before we dive into the details of it, I'd like to talk about some numbers and statistics. Now, approximately 7% of cases that present to the endodontist's office are that of referred pain. And among this, 80% of this non-odontogenic pain has been found out to be due to myofascial pain syndrome.
Thank you, Dr. Mishra, for sharing these numbers. Essentially, we're talking about two different scenarios. The first might be of patients who have not had any root canal treatment, and so they're presenting to the endodontist or to their dentist with what they think is a toothache. So in these situations, 7% of cases are going to be non-odontogenic in origin. And the second scenario is of what we call persistent endodontic pain. So this would be patients who had moderate to severe pain in their teeth. They had root canal treatment done on the tooth. And then after that, the pain attenuated but did not completely resolve. So this is what we call post-endodontic pain or persistent endodontic pain. And it happens in a very small percent of patients. When it does happen, what we have found is that 80% of this is because of some myofascial pain syndrome. In other words, when the patient first came to the endodontist or the general dentist, the pain that they were experiencing was both from the tooth, so of endodontic etiology, as well as it had a component which was non-endodontic. So doing the root canal treatment reduced the pain significantly, but there's a small component of pain that persists, even though there are no clinical or radiographic signs of disease.
That's absolutely right, which takes us to the point where we discuss about the concept of convergence. Why does a pain which is located at one point feel to be coming from the other source? Why is there difference between the site and source of pain? Now, here I can give you examples of two different situations where it's called homotopic pain, where the site matches with the source of pain. So let's say you have pain in the tooth and you have the source of pain coming from the tooth itself. Let's say it was an odontogenic pain. So you treat the tooth and the treatment plan is effective. On the other hand, you have a situation where the pain is heterotopic, which means the site doesn't match with the source, as was applicable in your case, where the pain was located in the tooth. That was the site of pain. But when we tried to probe further, the original source of pain was coming from the muscle. Now, what happens here? These afferent nerve signals traveling from the tooth and the muscle, they kind of converge together as they are entering the spinal cord, particularly the trigeminal sensory nucleus, traveling all the way up to the sensory cortex in the brain. And here, the brain is getting confused as to where the pain signals are coming from. This often leads to mislocalization of pain. And in this situation, if you go about treating the site of pain, which is the tooth, the treatment plan would be ineffective, which means the patient would come back to you with persistent pain because we did not target the source of pain. We were just focusing on the site where it hurts. Speaking about which, it takes us to the concept of musculoskeletal causes of non-odontogenic pain. We have myalgia, and then we have myofascial pain. Now, myalgia would refer to, of course, pain of muscle origin, but it's localized to the site of palpation. On the other hand, myofascial pain, as the name suggests, has a myogenic component and a fascial component. So it's the muscle and the fascia around it. When muscles pain starts spreading beyond that particular point of palpation to both the situations where the pain could be either located within the boundary of the muscle or the pain could extend beyond the boundary of the muscle to other distant sites. And myofascial pain is often categorized by the presence of trigger points, TRPs. What are they? They are localized hypersensitive nodules that are found in a taut band of skeletal muscle. And these are the ones that are responsible for the referred pain patterns to different sites in the body.
Yeah, so just to kind of clarify, say you've had a patient in your chair for a long, lengthy dental procedure, and because the patient had to keep his or her mouth open for a long time, they could develop myalgia in their muscles. And in this case, it's really the muscles which hurt. On the other hand, if the patients have developed myofascial pain, then that pain can, of course, is tended to palpate the muscles, but it also refers to other sites. And the problem really arises if it refers to the tooth and the patients are perceiving it as a toothache, but in reality, the source of the pain is from a muscular origin and not from the tooth itself.
Absolutely right. So this takes us to a discussion how to differentiate a muscle ache from a toothache and what are the characteristic features of a myofascial pain. So we talk about the location, intensity, duration, frequency, etc. So here we talk about the constant background pain that is present all throughout the day for a patient. The patient might tell you, I have periods of exacerbation of pain. The quality of pain might be described as a dull, achy soreness. The patient would often be not able to localize the pain. It would be a more of a diffuse pain pattern. There could be a referred pain pattern, there could not be. At the same time, you could ask the patient about additional symptoms of whether the patient has experienced stiffness of the muscle. If the patient has had limitation in mouth opening, the range of motion is limited. Additionally, there could be other factors which aggravate the muscle pain. For example, functional activity of the jaws, such as talking, chewing, etc.
Yeah, so this is really, I think, where some of the confusion arises. So as an endodontist, many patients who present with pain will complain of a dull ache. So that's a descriptor they use. They talk about having this constant pain, which is made worse by certain factors. And also, if for teeth which are fractured, when you have a crown to root fracture, they will have periods of exacerbation. So when we collect this data, it could be, again, odontogenic pain, or it could be referred pain. And then looking at the localization, what our data from multiple studies has shown is that as the intensity of the toothache goes up, the area of localization becomes poor. In other words, the pain becomes more diffuse. In fact, there was a very interesting study which showed that when patients only have pulpal pain, as the intensity of the pain increased, the patients themselves were unable to accurately localize the source of pain. So they could not tell which tooth the pain was coming from. However, once periapical symptoms develop, then the patients are able to tap on the tooth itself and say, oh, it's this tooth that's hurting. So that causes more confusion. And then when we talk about the associated symptoms like muscle stiffness or reduced range of motion, from a patient's perspective, they can say that, oh, yes, I cannot open my mouth as wide as I used to because I'm having a toothache. And lastly, about functional activity, when patients have symptomatic apical periodontitis, chewing on the tooth does make the pain worse. So even though all these factors are true for myofascial pain, from an endodontic perspective, I can tell you that some of these are also true for a true odontogenic pain.
That's absolutely right. And that's where the art of comprehensive history taking comes into play. You have to ask your patient about perpetuating contributing factors that could be leading on to the perpetuation of these symptoms of pain. You should ask the patient about parafunctional habits of, let's say, sleep bruxism, whether the patient clenches or has the bed partner or anybody in the family notice that the patient clenches and grinds their teeth during sleep. Are there any grinding sounds? Is the patient aware of any awake parafunctional habits of keeping their teeth together? Other habits like chewing gum constantly or nail biting, lip biting, cheek biting. There could be stressful situations which often lead to our patients developing tension in their muscles, holding tension in their muscles really tight. Also, last but not the least, we should definitely account for systemic contributors such as chronic pain conditions, patients with fibromyalgia. These are contributing factors that could lead to the perpetuation of the pain symptoms. What do you think?
Yeah, so thinking of clinical scenarios, sometimes you may have a patient who says that if I push on my tooth a certain way, it hurts. Or if I push my tongue against my tooth, it hurts. Now, really, it is their habits which are causing this pain to become persistent. So it's good to have patient education when we tell them, don't push against your tooth or don't use your tongue to kind of push against the inside of your tooth. And if you stop doing that, it will stop hurting. The other fact that you brought up about systemic contributors is very important. There have been many studies on chronic pain patients, so patients with, say, fibromyalgia, whiplash syndrome, certain types of migraine, where we see two things. One is that their pain threshold is reduced. So the way the nervous system responds to any kind of stimuli is completely different. So anything which might cause a little pain in us will cause a lot of pain in these patients who have chronic pain conditions.
Absolutely true.
The other thing to keep in mind is that when you provide treatment for somebody who has a chronic pain condition, the resolution of pain might follow a different pattern. So, for example, in patients who don't have a chronic pain condition, a comorbid chronic pain condition, when you perform root canal treatment, you know that the peak post-op pain is going to be for the first maybe 48 hours, and in a week's time, the pain is completely gone. However, for someone with chronic pain conditions, it might take them much longer for that pain to resolve. So it's really helpful to have that conversation with your patient even before you start treatment, saying, because you happen to have this chronic pain condition, the way your pain resolves after root canal treatment might be different.
That's true. And this leads to our next slide, where we talk about the 4 different muscles of mastication. We have temporalis, masseter, lateral pterygoid, and medial pterygoid. Moving on to how do we palpate the masticatory muscles? Is there any specific technique involved? How much pressure do we apply? So here's a brief video that we'd like to show you that demonstrates the techniques of palpation.
So today we are going to talk about palpation of the masticatory muscles. We are looking at masseter, temporalis, lateral and medial pterygoid. 3 things that we need to remember while palpating a muscle is, first, to look for tenderness and to be able to replicate the patient's chief complaint, whether the pain is familiar to the patient or not. The second is to look for trigger points, which are contraction knots formed within the muscle. The third point is to look for referred pain patterns, because if there are trigger points that are palpated within a muscle, that would often lead to referred pain patterns. Depending on which muscle we are palpating, the referred pain patterns are different. The second thing is, what technique do we use to palpate a muscle? There are 2. One is a flat method of palpation, where we use the dorsal surfaces of our fingers and go about palpating the muscle in this way. The second is a pincer type of palpation, where we use our thumb and index finger to grab the belly of the muscle. So it depends on which muscle you are palpating. Pincer palpation is particularly used for the cervical muscles. We don't do that much for the masticatory muscles. The third aspect would be, how much pressure do we apply while palpating a muscle? So if we go by the textbook standards and the AAOP guidelines, it's about 1 kilogram of pressure, which relates to about 2.2 pounds. But how do we relate that into a clinical scenario? So what I would suggest is to use a single firm thrust of pressure, which is sustained for about 5 to 6 seconds, rather than going with gentle thrusts that are moved around.
So here we talk about techniques in general about palpating different muscles. I'd like to show a graph where the study was done by our very own Dr. Ed Wright, and it was published in the Journal of American Dental Association in the year 2000, where he kind of evaluated the frequency and the sources in which the muscles, masticatory muscles, refer pain to the teeth. And what he found out was that masseter muscle, if you can look at the numbers here, we have the maximum numbers for the masseter muscle. So that's the main muscle that is involved in the concept of referred pain to the tooth. Also, we see here that mandibular molars are the ones that the masseter muscle refers pain to the most.
Yeah, so an excellent contribution by Dr. Ed Wright, who we miss very much at UT. So basically, to reiterate, if you suspect that the source of pain is from one of the muscles of mastication, the first muscle to palpate should really be the masseter muscle. So let's go further into that.
Sure. So here we are looking at the different referral patterns of the masseter muscle. If you look closely, we have the X's marked as black X marks. There are the locations of the trigger points. The superior portion of the superficial fibers refers pain to the maxillary molars. The belly of the muscle refers pain to the mandibular molars and partially to the body of the mandible. The point of insertion of the masseter muscle refers pain to the mandibular body and the frontalis area, whereas the deep fibers refer pain to the ear. And we'd like to show a video of how do we go about palpating the masseter muscle.
We can use a flat method of palpation using circular motion and applying single firm thrust of pressure sustained for about 5 seconds. And we look for tenderness, which is familiar to the patient, maybe trying to replicate the pain. And the second would be to look for trigger points. We'd repeat the same process as we go down the belly of the muscle and finally along the point of insertion of the muscle. Finally, when we want to palpate the deeper fibers of the masseter muscle, we could ask the patient to clench, and we can feel the muscle pop up right beneath, in front of the preauricular region. So we are asking the patient to clench, we feel the muscle pop up, and we can ask the patient to relax, and we can feel for the deeper part of the masseter muscle in front of the preauricular region. Now, finally talking about the referred pain patterns. For the superficial fibers, the superior part refers pain to the maxillary molars, the belly of the muscle refers pain to the mandibular molars, and the point of insertion refers pain not only to the body of the mandible, but all the way up to the frontalis area. Now, the deeper part of the muscles, if there are any palpable trigger points, they usually refer pain to the ear, leading to symptoms of ear stuffiness, ear pain, etc. Now, would you like to palpate the other side?
Yes, please. Turn that way, please.
No.
Okay, so this is taking us back to case number 1, where we showed that palpation of the insertion point of the masseter replicates the patient's pain, which he was perceiving as coming from tooth number 31. So this is just a simple fictionalized example of how pain from the masseter can refer to one of the teeth. So before we go into resolution, I would really want to share some other case scenarios with you. So this is another patient. This time it's a male patient, Mr. NK, who had first presented to my clinic with constant pain made worse by both chewing and by cold. So in this patient, we diagnosed tooth number 14 as having symptomatic irreversible pulpitis and symptomatic apical periodontitis. So we completed root canal treatment in 2 visits. All 4 canals were found, debrided and obturated. And so this patient came in with a pain intensity of about 6 on a scale of 0 to 10. So on a routine 6-month follow-up appointment, the patient now says that my tooth still hurts. So when I questioned him about it, the pain intensity was much lower. It had dropped to a 1, so 1 on a scale of 0 to 10. But of course, the patient is questioning why his tooth still continues to hurt, even though we do not have any other signs of disease. So this is another situation which could be of referred pain.
And in this particular case, as we said earlier, the first and the foremost muscle that we need to look into when we are suspecting any myofascial pain referring to the tooth would be the masseter muscle. Let's say we palpated the masseter and we found out that we were not able to elicit the familiar pain pattern in the tooth. Could there be any other muscle that could be referring pain to the tooth? Let's talk about other muscles. So here we have a video that shows you palpation of the temporalis muscle.
So now we are going to talk about the temporalis muscle. As we know, temporalis is a big fan-shaped muscle that originates from the superior temporal lines and goes all the way down below the zygomatic arch to get inserted into the coronoid process. So if we want to palpate the temporalis, we will use the same flat method of palpation using a circular motion, applying single firm thrust of pressure, which is sustained for about 5 seconds. And we start off with the anterior fibers, the middle fibers, and the posterior fibers. So sometimes I do recommend asking the patient to clench. So when the patient clenches, you can feel the muscle pop up beneath the fingers and you know the extent of where to start and where to end. So we start off with the anterior fibers, the same way, applying a single firm thrust of pressure sustained for about 5 seconds. We ask the patient for any familiar pain pattern. Are we able to replicate the pain for you? Then we go about doing the same thing in the middle fibers and all the way back behind the ears for the posterior fibers. Now, a thing about temporalis and its referred pain patterns is the anterior fibers refer pain all the way to the maxillary anteriors and to the ala of the nose. So sometimes you might see patients complaining of anterior toothache or pain around the nose. The middle fibers of the temporalis, they refer pain all the way up to the premolar region, and the posterior fibers sometimes refer pain to the molars and sometimes at the back of the head. Would you like to palpate on the other side?
Yes,
or the
please.
side, please? Yes.
So would you turn the other way, please? Thank you.
The anterior fibers, the middle fibers, and the posterior fibers.
So in this case, coming back to your case number 2, where the patient had persistent pain in the upper molars, it could be possible that on palpation of the posterior fibers of the temporalis, you could be able to elicit the familiar pain pattern in the maxillary molar. So this is a pictorial representation of the referred pain patterns of the temporalis, which we just discussed.
And of course, there's the last muscle that we want to talk about is the lateral pterygoid. So when I trained a long time ago, I was taught how to palpate the lateral pterygoid. It was not a fun process for me or for the patient. So then what happens is you stop doing it. But I'm very glad to learn from Dr. Mishra that now instead of palpating the lateral pterygoid, we can use functional resistance to see if there is any myalgia or myofascial pain associated with this muscle.
Absolutely. And I'm very glad we brought this topic up because traditionally and conventionally, lateral pterygoid muscle has been palpated using an intraoral approach. But I'd like to show this video where we talk about why is it not being continued so far. I assume some practitioners do feel comfortable doing the intraoral palpation, but the reason why we have moved from doing an intraoral method of palpation to something called as a functional resistance method.
So now we are going to palpate the lateral pterygoid muscle. Conventionally, lateral pterygoid muscle has been palpated using an intraoral approach, but because of the anatomical location of the muscle, it's practically not possible to do an intraoral approach because when you take your little finger and try to go intraorally, turning it behind the maxillary tuberosity and asking the patient for tenderness, it invariably leads to false positive results from most of the patients. So what the latest guidelines suggest is to use something called as a functional resistance method, where we are activating the lateral pterygoid muscles and checking it for any tenderness against the function. So lateral pterygoid muscle has its function in protruding the jaw forward. So when both sides lateral pterygoid muscles contract, particularly the inferior part of the lateral pterygoid, they help in protruding the jaw forward. So what we are going to do is we are going to use our thumb and apply pressure onto the chin, which is the midpoint, and ask the patient to resist our force, which is in a backward direction or a posterior direction, and ask the patient, resist my force and try to bring your jaw forward. Thereby, we are causing activation of the lateral pterygoid on both sides, and if the patient has pain, they would elicit and tell you that, oh yes, that hurts. Would you like to try it on the patient?
Absolutely. Would you please look straight ahead? Okay, I'm going to put some pressure here. Can you move your jaw forward? Alrighty, does that hurt?
No.
So now I'm going to try test the lateral pterygoid just on the right side. So now as I put pressure, move your jaw to the right. Great. Did that hurt you?
No.
Excellent. And now the same thing on the left. I put pressure, move your jaw to the left. Did that hurt?
No.
Excellent.
So I hope you found these videos helpful in learning how to do palpation of the different muscles of mastication. This picture here shows us about the referral pain patterns of the lateral pterygoid, not as much to the teeth, but then referred pain patterns to the ear, leading to symptoms of ear stuffiness, ear pain, and also referred pain to the maxillary sinus. So patients would often report that, apart from the tooth, I feel some sort of a pain in my sinus, but I don't have other symptoms of, let's say, nasal stuffiness, discharge, and other symptoms that relate to a sinus issue.
Oh, fantastic. So we've talked about some case scenarios, really 2 case scenarios and 3 different muscles. But given the in interest of time, let's go on to talk about how we would manage some of these patients who present with referred pain.
Absolutely. And before we go on to that, I'd like to highlight some key points which say that there is no absolute hierarchy of treatment when you want to treat myofascial pain. It depends on person to person. You have to have a customized patient-based treatment approach and formulate a plan that suits best for your patient's needs. And at times, you would often need multidisciplinary management for patients. The first step, of course, which I feel is the most important, is patient education and reassurance. Explaining to the patient what's going wrong and why is there a mislocalization of the pain often leads to solving half of the questions patients has in his mind.
Yeah, so I think this is where it can be a little bit challenging for some of us, because patients come to us, they think they have a toothache and they want a quick, easy solution. They want you to say, okay, this tooth needs this kind of treatment, and once we do it, you're going to be pain-free. So explaining to the patient that, well, you feel it's a toothache, but it's not really coming from the tooth. So any kind of treatment to the tooth, whether it's going to be performing root canal treatment or even extraction of the tooth, is really not going to resolve the pain. The second thing is about the patient's mental state. So for most of us, if we have been in pain, especially moderate to severe pain for a few days or a few weeks, it does lead to some anxiety. When you go to a dentist and you think you might need root canal treatment, that leads to some anxiety too. So it's important for us to be aware of the patient's mental state so that we approach them from a position of compassion and they feel that they're really being taken good care of, instead of us just kind of saying, oh, it's not a toothache, so treating that tooth is not going to help you.
Of course, reassuring the patient and acknowledging the fact that they do have pain, but it's not really coming from the tooth. The second step would be self-management strategies. How can you equip your patient and make them capable in a way to manage their own pain? First of all, when you look at a patient from a wholesome approach, you look at the different contributing factors. You tend to teach them to be more conscious and aware of their parafunctional habits to avoid them. Ask them to maintain a good posture. You ask them, because posture is very, very important, because if we are constantly slouching with a forward head posture, it also affects our cervical muscles, and they play a role in referring pain to the masticatory muscles which in turn could be felt as a toothache.
Yeah, so let me jump in here again. So again, this whole habit of pushing your tongue against teeth, we have seen a few cases where it leads to persistent post-endodontic pain. So for example, treatment done on, say, tooth number 31, everything was done correctly, the tooth was restored, there's no sign of infection. But if the patient now develops this habit of continuously using his tongue to push against the lingual part of tooth number 31, they might feel some pain. And in their mind, they might be thinking, well, why does this tooth still hurt? In reality, the tooth is not hurting. It's the stress on the tongue muscles which is causing them to perceive a toothache. The other point that Dr. Mishra brought up was about posture. So in today's world, all of us are on our cell phones, and therefore it leads to kind of a posture where you're constantly looking down. In fact, even when you have a patient in a chair, they are on their cell phones and they're using the University of Google to double check everything that you're telling them. So this poor posture can definitely contribute to some myofascial pain conditions.
The third category of self-management strategies would be to stretch our muscle, because our goal should always be our muscles know only one thing. Whenever there is a stressful situation, they tend to contract. So our goal of treatment would be to stretch out and relax the muscles. You could either apply heat or ice packs, but more importantly, you should follow up that heat or ice fomentation with stretching exercises for the muscle.
Yeah, so that's a really interesting thing. Should we use heat or ice? So when I have a patient on whom they had to keep their mouth open for a long time, I ask them to use moist heat on their joints in order to avoid any post-treatment myalgia. So I use it as a preventive measure. But there are some people who recommend the using of ice packs instead of moist heat. So what are your thoughts on that?
That's an excellent point that you brought up, Dr. Khan, because based on what we've learned and what experience has taught us from interactions with patients is ice packs are reserved for periods of acute inflammation. So whenever you have a patient with, let's say, an acute muscle spasm sitting in the dental chair for about 3 hours and the lateral pterygoid goes into a spasm, you can feel the warmth along with the tenderness. It would be advisable to use an ice pack in that situation. But in cases where you have a patient with chronic muscle pain for a very, very long time, there are no signs of inflammation involved, and you expect the symptoms to resolve over a prolonged period of time. In that situation, I feel heat packs would be more effective. Even within the heat packs, it's just my perception and experience that I have, because there are no clinical trials that suggest moist heat works better than dry heat. Studies have been done on both, and both have been found to be effective. But based on my interaction with patients, moist heat tends to travel tissues, penetrate tissues in a better way, and patients comply better with moist heat packs, where you just take a regular face towel, dip it in hot water, wring it out, or let's say throw it in the microwave for 30 seconds and have it cupped around your face for about 10 to 15 minutes. And if required, repeat the process if the towel is getting cold. But then after about 15 minutes of muscle being warmed up, there is increased blood flow to the muscles. You can follow that up with some stretching exercises of the muscle, leading on to that actually heat helps you stretch out the muscles to a greater extent and helps you stretch out without the pain.
So what about as a preventive measure?
As a preventive measure, I feel using moist heat would be better because you don't have the active inflammation involved, and heat can go a long way in preventing the onset of the myalgia.
Right. So after a long dental treatment or a long endodontic treatment, then using moist heat as a preventive measure is a good way to prevent postoperative pain.
Moist heat with stretching exercises.
Yes.
And lastly, you need to train the patient to learn the habit of a relaxed mouth position. That is, I think, is the most important point nowadays, where our teeth are never meant to be together. Even while eating or chewing, there is food between your teeth. So teeth should always be slightly apart, the lips should be sealed, and the tongue should be resting against the roof of the mouth. This is called the relaxed mouth position. And if we want our muscles not to be tensed and strained out, which we subconsciously do throughout the day when we are working, we are focused on something, we need to practice the relaxed mouth position.
Really good points. I'm tempted to kind of make these little cards with all this information on them so I can hand them out to patients so they can remember.
That would be so helpful for them. The next strategy of non-pharmacological management of referred pain could be the use of an oral appliance, whether you call it a night guard, a bite splint, a dental splint, whatever name you give them. Two most important points are when do you advise it and how do you deliver it. You advise it for a patient who you cannot opt for a night guard for every patient who walks into your clinic, right? And that is an important thing that dentists need to be aware of. If you have a patient who, apart from having muscle pain, has a chronic history of bruxism, which is the subjective report, objectively, you also notice severe wear patterns on the teeth. The patient has severe dentinal hypersensitivity. The patient has a pronounced linea alba, and you feel that these symptoms are contributing a lot to the myofascial component of pain. Then that would be a good situation where you want to give an occlusal hard stabilization splint where it's equally balanced. So how do you deliver it? Not just get it from the lab and then just hand it over to the patient. Make sure it's fitting well, is retentive enough, and ensure that the night guard is balanced on both sides equally, because one high point on the occlusal plane could lead to overactivity of the muscle and exacerbation of pain rather than treating the muscle pain.
So you're telling me I can't have my patients walk down the street to the closest pharmacy and pick up?
Absolutely not. So I am completely not in favor of the over-the-counter night guards, particularly. I mean, you could use that as, let's say you have a sports match and you want to protect your teeth from the injury. You could use a boil and bite night guard. But when you have chronic pain conditions like this and chronic history of bruxism, you definitely need a customized night guard, which is well balanced by a specialist.
Now to the interesting part about pharmacotherapy. So I'll let you get started.
So we have over-the-counter medications, which the patients can take on an interim period before they get to meet with the specialist who can manage their pain. They can have ibuprofen, naproxen, ketoprofen. Although topical anti-inflammatory medications do work well, but there are very limited clinical trials that prove its efficacy. I would strongly suggest that when you have a patient in your chair and you feel that it needs, further intervention by a specialist, and there is a time lapse between the patient being referred from your clinic to the time where they get to see a specialist, that time frame can be used by the patients to use these over-the-counter medications. What do you think?
Yes, what you're telling me is in that time lapse, they can either take NSAID systemically, or they can maybe try using a gel like Voltaren gel.
Of course.
Which is diclofenac sodium, and just apply that. But I have another question. What about combining an NSAID with acetaminophen, so Tylenol? Can we do that?
So that's a good point. Although research has shown better results with combination therapy, where you have acetaminophen contributing to the analgesic part of it, and then you have ibuprofen, let's say, for the anti-inflammatory part of it.
Yeah.
But although it has, in a combination basis, it has improved results. But I would feel that if there is no inflammation involved in the muscle, we would strictly, focus on only prescribing topical analgesics or systemic analgesics, which would help in relieving the pain part symptomatically. But then again, with over-the-counter medications, you have the risk of patients overdosing, and you have to deal with other side effects of, gastric side effects that could be caused because of over-medication with over-the-counter drugs. The next category would be prescription medications, wherein we have muscle relaxants, we have tricyclic antidepressants. Now, what do we know about muscle relaxants? As per what research has shown is muscle relaxants are typically used for a short-term period, particularly for acute muscle spasms, or for a patient who has been a chronic TMD patient or chronic myofascial patient and has periods of flare-ups and periods of, alleviation. Cyclobenzaprine being one of the most commonest medications as a muscle relaxant to be used, given at a dose of 5 to 10 milligrams on a nightly basis. And statistically, it has been shown to prove better in comparison to a placebo or clonazepam. The thing with cyclobenzaprine is because of its side effect of sedation, you need to be cautious to explain the patient that because of the half-life of the drug, the patient might feel groggy or sleepy the next day. And that leads to you to explain to the patient that you need to take the medication not at bedtime, but a few hours before bedtime, which will prevent that sensation of grogginess the next day when they wake up. With baclofen, although baclofen is being used very often for targeting muscle pain, but I would strongly suggest not to use it as the first line at a dosage of 5 milligram thrice a day because it has a shorter half-life. The side effect profile with baclofen is more, I feel, in comparison to cyclobenzaprine, particularly because baclofen being an antispastic agent as well, apart from a muscle relaxant, and primarily used in other muscle conditions like multiple sclerosis, where there is a lot of muscle stiffness involved. And as a side effect, it leads to muscle weakness because it prevents that severe contraction of the muscle. Having said that, I would comment that there is limited evidence to show that muscle relaxants alone are efficacious in treating myofascial pain. Often used in combination with self-management strategies like muscle stretching, heat fomentation, stretch and exercise, also in combination with other analgesics and anti-inflammatory medications.
Yes, so just to clarify, when you talk about chronic pain, you're saying 3 months or longer?
Absolutely.
Right. So sometimes when we see patients in the chair and we're really trying to, make the right diagnosis, they may not have had that pain for so long. It might just be a few weeks, like, the couple of cases that we started with.
Mm-hmm.
So for these cases, an acute myofascial pain presenting as a toothache, have there been any clinical trials which have compared cyclobenzaprine and baclofen head to head?
Not to my knowledge. That would be a good research study to do. But then again, because of the side effect profile of baclofen, I think that is why we have limited evidence in the treatment of myofascial pain of the masticatory muscles per se. But going back to your clinical case where there is an acute history of pain, we could try the patient on cyclobenzaprine, let's say, for a safer side effect profile, and have them take the cyclobenzaprine for a period of 7 to 10 days and see how they respond to it.
Great. And if they don't respond, or you see you're not clear what to do next, I guess that's when we need to refer. So, most of us are not trained on managing chronic myofascial pain or managing chronic TMD. So I think this is when we refer to a specialist like yourself, and depending on the complexity of the diagnosis and also looking at how refractory the pain might be. So tell us a little bit about the different modalities that you can offer as an orofacial pain specialist.
Absolutely. As you mentioned, knowing your boundaries and knowing the scope up to which you can do a treatment for the patient is absolutely important, only because you don't want to mismanage. The whole idea is to create awareness as to not cause any unwarranted dental treatments for the patient. Now, the modalities that an orofacial pain specialist can offer, apart from the first line of treatment that is usually done, is options like spray and stretch, where ethyl chloride spray is, sprayed onto the muscle, and specific training is provided to the specialists how to stretch out the muscle in a way that it leads to effective results. We also have the option of doing trigger point injections by the specialists, where you could either use saline, you could use lidocaine or local anesthetic, or the concept of Botox. And I don't want to go into details about Botox because that would lead to a whole new lecture. But these are the treatment options that a specialist can offer, along with other multidisciplinary adjunct treatment modalities like physical therapy and other forms of physical medicine. This leads to the end of our discussion, and now we open the floor to any questions or comments.
And thank you all for your attendance. And I want to also shout out to Vanessa, who was our model for the videos that we took. Thank you very
so much, Vanessa. And thank you to the team of Echo.
Thank you so much, Dr. Mishra, Dr. Khan. That was a great presentation. And all the demonstration videos, those were great. It's always valuable to see those techniques in action. So thank you so much for sharing that with us. If you have any questions, please feel free to drop it in the chat, or please unmute and let us know. If you have any questions.
Trying to look into the chat to see if there are any questions. Okay. I don't see it's on the chat, but we are open to any questions.
Yep, I see one from Dr. Colbert. What about using TENS unit?
TENS units.
All right. So the thing with TENS unit is, as I mentioned, it's an adjunct treatment modality. And when I mentioned about the key takeaways of management techniques, we need to know that there is no guideline as to what could be best for a patient. Each patient comes with their own set of symptoms and their own set of additional factors that contribute to the symptoms. So while TENS unit is applicable in some patients, it would not be the go-to treatment modality for all patients who have myofascial pain. There are situations where TENS unit might be very helpful in bringing about, therapeutic results. But would you opt for a TENS unit right away for a patient? I would say no. I would say first go with the conservative treatment strategies first. Talk to the patient. First of all, educate the patient. Let them know that this is why things are happening. This is why your muscles are constantly tensed, and you need to train yourself to, I know these are not quick fixes, and patients would not be happy saying that, oh, I left from the dentist's office without getting any treatment done. But we need to educate and make the patient aware that these are things that will help the patient in the longer run. So for them, we need to start off with the conservative strategies first, and then talk about other, let's say, more aggressive techniques or more invasive techniques. TENS unit would definitely, I'm not against TENS unit. It is definitely a very, very good modality to be used. But again, I would say it's not the ultimate treatment modality, or it's not the only treatment modality that could be used in your patient. You could have a combination of treatments that could be helpful in bringing about the expected therapeutic results.
Great.
Are there any questions? Thank you, Dr. Colbert, for your question. I'm trying to get to the chat for any
Feel free to drop any questions into the chat if you have any. We have time for a couple more questions before we end.
As I'm going through the chat for questions, I see a lot of compliments and thank you for your wonderful presentation, which I 100% agree with. It was very informative. Thank you for sharing your knowledge with us.
Thank you so much. And I thank Dr. Khan so that we had this interactive session so that, we kind of, I think the reason why we are not getting enough questions is because we ourselves asked each other the questions that are probably could be asked by the providers or the dentists. Mostly commonly expected FAQs.
I don't know, either that or everyone has gone to sleep. It is lunchtime, so.
But thank you, Dr. Dhar and the entire team at DentEcho for giving us this platform to make this informative and educative, presentation, because this is something that I believe every dentist would have encountered in their lifetime of practice. And this would not only teach them or make them aware of other possibilities, also, more importantly, prevent them from doing unnecessary dental treatments if they are not sure of, or if they think that it is not coming from the muscle, not from the tooth, they should not go ahead with the treatment unless they are really sure it's coming from the tooth.
Thank you. And please remember that the recording and slides, it'll be shared after session on our DentEcho website. So if you want to go back to any part of it, you can do that. Any more questions before or comments before we close the session? right. Taylor, if you can please share the conclusion slide. All right, perfect. Thank you. Thank you, everybody, for joining us for the 27th DentEcho. Please complete the post-session survey using the link in the chat, and also you can scan the QR code that you see here. And we hope to see you in 2 months in September.